Okay, some definitions really quickly. You're all going to know these: ALL, acute lymphoblastic leukemia, AYA. So AYA is defined by the NCI as between the ages of 15 and 39. They're pretty generous with their definitions. PH positive stands for Philadelphia chromosome positive. That's a translocation of the 9 to 22 chromosome. That's important in ALL. PH-like are a whole growing family of mutations that actually sort of behave like the Philly chromosome. And then MRD stands for minimal residual disease. It's a term you're going to see throughout the talk. And that depends on how you're measuring it. But for the most part, for leukemia, still we're talking about using high-resolution flow cytometry. Okay, so why is a pediatrician talking about treating 30 and 40-year-olds? That's a really good question. And there's lots of answers to it. One, I can tell you that my adult colleagues, internists and oncologists, most of their experiences is with people over the age of 60 or 70. And most 20-year-olds, a lot of young 30-year-olds, are a lot more like my teenagers physically and the diseases that they get than they are like 60 or 70-year-olds. Psychologically, the 20-year-olds are an awful lot more like our teenagers, right? As anyone who's ever dealt with young adults will tell you, things like compliance, it's like dealing with an 18-year-old oftentimes, right? The same kinds of issues come up. And then in addition, young adult patients have a whole special set of social needs that are really truly not met by adult oncologists or truly by pediatric oncologists and actually are unique to them, right? And so I think a pediatrician takes this on relatively well, though. But the major reason in terms of leukemia, why we can say this is ALL, acute lymphoblastic leukemia, is a pediatric disease. If you look at the incidence of ALL, it is highest in kids between the ages of 5 and 9, right? So pediatricians are good at ALL. We see it a lot. In the adult world, it's kind of the rarer leukemia. My adult colleagues see myeloma a lot. They see AML a lot. The ALLs that come in for them are the rarities. Every pediatric oncologist sees a lot of ALL. It makes up 35% of our diagnoses. Right? And we're good at it. Okay? We are probably the greatest success story in modern medicine. If you look at survival for pediatric ALL, in my lifetime, 1960s, early 1960s, every kid who got ALL died, right? Usually relatively quickly. Right? What happened in the 1960s, it was a golden age for combinatorial and synthetic chemistry. We were coming up with all these new compounds to try, throwing them at kids because we didn't know what else to do. First, one at a time, and we induced some short-term remissions with some of these agents, methotrexate and Christine, and then got the bright idea of trying to combine them. And that actually made a big difference. Combining different chemo agents helped a lot. We started to induce longer-term remissions. But if you look at the survival curves, the real big advances took place in the 1970s because we had the advent of a drug called pegylated asparaginase, or asparaginase initially, now pegylated asparaginase. Asparaginase is really kind of cool. Unlike most of our cytotoxic agents, it's pretty targeted. What it does is it depletes your body of asparagine, and it turns out that asparagine is a non-essential amino acid for most of the cells of your body. Not for lymphoblast, they need it. So you deplete asparagine, the lymphoblasts die. So the huge advance in survival that we see in the 1970s is largely due to incorporating asparaginase into a backbone of chemotherapy that was designed in Germany called BFM, Berlin, Frankfurt, Munster. The Germans are really good at leukemia. They still are really good at leukemia. But even within pediatrics, there are different degrees of risk, right? Low risk kids, first of all, to be a standard risk ALL patient, two things have to be true. You have to be between the ages of 1 and 10, and you have to have a white cell count that was under 50,000 when you presented. You can never be a 13-year-old and have standard risk ALL because age is an independent risk factor for leukemia. Right? We do know that certain mutations are higher in older kids. Right? We know that babies with ALL below the age of 1 tend to do really badly, largely to do with the fact that they have an MLL gene rearrangement. That's changing now too, which is really exciting. But traditionally, that was a terrible diagnosis. Age itself, though, is a independent high risk factor. So that means by definition, when we're talking about young adult patients, they are all very high risk patients. So this is a slide that compares traditional therapies. So for reasons that are not completely clear to me, adults had one way of treating ALL and pediatricians had another. Pediatricians, we did almost all of our studies in national kind of cooperative group studies. The adults developed them independently. But the mainstay of treatment that then developed from that is the modified BFM, the Berlin, Frankfurt, Munster protocol that I was telling you about in pediatrics, while the adults use something called hyper-CVAD, right? The difference between these are some of the agents are the same, right? The adult hyper-CVAD has cyclophosphamide, vincristine, daunorubicin, right? But it's kind of the same cycles repeated over and over again. It's much more myelosuppressive. It doesn't use antimetabolites, which we use an awful lot in the BFM protocol, like 6-MP and methotrexate. It doesn't use asparaginase, right? And it's not divided into these phases. If you talk to adult oncologists, even now, adult leukemologists, they hate our pediatric protocols. Oh my God, you have induction, you have consolidation, you have intermaintenance 1, and intermaintenance 2, and delayed intensification. They don't like that. They're used to the idea of repeating the same cycles of drugs for. So anyway, that was the way it was. And in the early 2000s, there were lots of anecdotal small study reports that said, hey, these 20-year-olds who came into the pediatric side seemed to do pretty well. But that wasn't the case when they went on the adult side. And then in kind of the mid-2000s, when Naveen and I were at the University of Chicago, the two people that are in that photograph are people we know very well. Wendy Stock, who is an adult oncologist at the University of Chicago, and Dr. Jim Nachman. Jim Nachman trained Naveen and I. He was the PI for several of the COG studies, and he used to argue with Wendy in his voice that is really hard to describe. Naveen can do it better than me. Naveen, do a Jim Nachman.
Wendy, we're doing so much better than you.
That would be it. Jim was a 6'3" man with a very loud, very high-pitched voice. And he would say, you're doing this all wrong, right? What are you doing to these? Our kids, our 23-year-olds that come into our side, live, yours die, right? Wendy took this to heart, right? She really did. And she said, well, let's do a national trial. And they did. She organized a national trial through the CAL group, and it recruited 318 patients in a single-arm study, and it compared pediatric therapy for patients up to the age of 39 to traditional hyper-CVAD. Look at the survival rates. So traditional survival for patients treated with adult therapy was about 35%. Patients treated on this study, survival was 79%. That's a pretty big increase. Right. They found that the PH-like mutations did worse, and also patients with obesity tended to do a little worse, but overall this was such a significant finding that it really was a game changer. And a lot has happened over the last 8 years. 25 studies now have been done looking at pediatric versus adult therapy. 23 of them showed pediatric therapy had superior event-free and overall survival. Only 2 of them did not. Those 2 studies both come from MD Anderson. MD Anderson found equivalent rates with hyper-CVAD in their hands to pediatric-style therapy, but they're the only ones. No one really knows exactly why. And a meta-analysis that was done, again, demonstrated that there's much higher rate of overall survival, event-free survival when using pediatric protocols for this age group. However, anyone who's used this therapy in young adults does know that they do tend to have more toxicities and more severe toxicities than our little kids do, especially with the agents like asparaginase or high-dose methotrexate. Even vincristine, actually, they get a lot more neuropathy and it lasts a lot longer, right? So what we've had to do is adopt some of these therapies for this age. So this is actually relatively recent data that Wendy published about a year and a half ago from that same CalB study, but it really is a game changer in that it answers something. In the adult world, after you got hyper-CVAD for multiple cycles, you almost always went to transplant. And so the adults would say, well, our patients who do get transplanted probably are doing as well as your patients who've gotten traditional pediatric therapy. Not true, all right? Overall survival, if you did pediatric cell therapy, is better than adults who went to transplant. Turns out that one of the major reasons for that, not surprisingly if any of us do transplant, is that non-relapse mortality in the transplant arm is pretty significant. And so when that's weighed in, this kind of answers that question. In this age group, pediatric therapy has an overall higher cure rate. So now I'm going to talk about some not so new agents. All right. Before I do that, just a little quick slide of a B cell. All right, so on B cells, they have proteins that identify them. They're important in their function, but they're also important in identifying for us diagnostically what's a B cell. And the two I want to draw your attention to are CD19 and CD22. Found on B cells, not found on T cells, not found on other blood cells. They tell you you're a B cell. And we take advantage of those for the next two therapies that I'm going to talk about. Blinatumomab. Blinatumomab is really cool. It's a bivalent antibody. It binds to CD19, and it binds to the T cell receptor. It brings a T cell to a B cell. The T cell chews up the B cell. Really kind of nice, right? And the first studies for this, I did not know this until I put this talk together, were actually done at the same time that Wendy was organizing the CAGLA study in Germany. Again, the Germans, where they took 20 relapsed and refractory patients with ALL, and they gave them this antibody, and they saw a very high 65% response. These are patients who had already received therapy, as we always do. We tested in relapsed refractory and had a really encouraging response. So over the next decade, we did multiple studies of blinatumomab in relapsed refractory patients. And the data were enough to easily convince the FDA to approve blinatumomab for relapsed adult patients in 2014. And then, as it always goes, it took a lot longer for the kids. It was 2023 before it was approved for that same patient, or for kids for that same drug indication. Now, this is really exciting recent data. This was published within the last year. Those are for relapsed and refractory patients. Right. This is from a study, an ECOG 1910 study, looking at patients between the ages of 20 to up to, I think, age 50, or 30 to 70, I'm sorry, I actually have it on there, I should have just looked. And it enrolled 488 patients. And 224 of those patients were MRD negative at the end of the first cycle of chemotherapy. Right, and they put 112 patients into each arm of the next study, and they gave blinatumomab to 112 and didn't to the others. And this is very exciting. The MRD negative patients who got blinatumomab had a higher overall survival rate. This means that blinatumomab should not just be being used for patients who are relapsed and refractory, but it should be integrated into upfront therapy. The nice thing about blinatumomab, too, is those of us who've used it, its side effect profile is really nice. The side effects that you see with blinatumomab, CRS, cytokine release syndrome, that usually happens in the first couple of days of a cycle. You use dexamethasone, it usually goes away. Excuse me, there are neurotoxicities that are associated with it, but actually in my young adults, I seldom see that. That tends to occur much more frequently in older adults. We have two ongoing pediatric trials right now for blinatumomab. One is investigating it up front for standard risk ALL in kids. It's a COG study. And this one is really interesting. It's using it with nivolumab, right, for relapsed and refractory patients. So basically chemo-free reinduction. That could be very exciting. Excuse me. Now another agent, inotuzumab. Remember I told you CD19 and CD22. This is where CD22 comes into play. Inotuzumab also works in a pretty cool way. Unlike the bivalent antibody that binds both the T cell and the B cell, inotuzumab just binds the B cell, but it's linked to a chemo agent, osagamicin, right? So that you're delivering the chemotherapy specifically to the cell, chemotherapy is taken up and kills the B cells. Pretty cool mechanism, right? So study in 2016, it was a phase 3 trial of 326 patients, looked at relapsed and refractory ALL patients of a median age of 47, and it showed a CR of 80% in these patients versus 29% for the patients treated with chemotherapy alone. Progression-free survival was more than 3 times as high. Overall survival was 7.7 months, and there were no, the major adverse effect that we do see with inotuzumab is VOD. Right? That happened in about 11% of the patients, especially those patients who go on to transplant. Multiple studies were done of inotuzumab, and in 2017, the FDA approved inotuzumab for adult patients with relapsed and refractory B-cell ALL. We have an open pediatric trial right now, which moves this to upfront therapy. This trial has been the bane of many of our existences because it keeps opening and closing, but hopefully we'll share some great data, so we'll be integrating this agent into upfront therapy as a standard relatively soon. Now, this is very recent data that Wendy Stock actually presented at the transplant meeting that I was just at last week. Chemotherapy-free treatment of using inotuzumab and blinatumomab. This was done in the patients that are over 70. Those patients tend not to tolerate chemotherapy very well, right? And so they were induced by giving up to 2 to 3 cycles of inotuzumab and then blinatumomab maintenance. And the response was amazing. Of the 30 patients that they did this in, all of the patients at the end of, so far they've only been following for over a year, it had a response rate of something like 78 or 80%, right? So that may be getting translated into younger patients soon too. So I told you that young adult patients have different types of leukemia as well within the ALL group. And one of the more common things are these PH-like mutations. These are like the Philly chromosome, but not. I'm going to talk about the Philly chromosome later when I talk about special ALLs. Anyway, these mutations are within pathways. Some of them are tyrosine kinase pathways, some of them are within the JAK pathway. And we have agents that can be used for these and integrated into chemotherapy. Right. We have the tyrosine kinase inhibitors that have revolutionized the treatment of CML that can be added for those that are within the tyrosine kinase pathway mutations, and then the JAK2 inhibitors as well. Both of these are currently being studied. There's a pediatric trial where the data still has not yet been published, but it looks like it's probably encouraging. So if you have a patient with a Ph-positive mutation within the tyrosine kinase pathway, adding a TKI into therapy does seem like it improves overall survival, but we are waiting for that data to be published. And these are some special subtypes of ALL. This is the Philadelphia chromosome. The Philadelphia chromosome, by the way, I'm going to get to talk about the University of Chicago again, Naveen, and I got to hear about this quite a bit, is a translocation of the genes BCR and ABL. Right? ABL stands for Abelson. Abelson happened to be Herb Abelson, who was the chair of pediatrics at the University of Chicago, who discovered that gene. And then the head of our cytogenetics program was a woman named Janet Raleigh. Janet Raleigh was kind of amazing. She basically is considered the founder of cytogenetics. She's the one who actually kind of showed that Philadelphia chromosome translocation was what gave rise to CML, and then many, many other things. A remarkable woman. She also had 5 kids and ran a lab at a time when women didn't do that. She just passed away a few years ago as well. Right. So Ph-positive ALL in kids. It's far less frequent in kids than it is in adults. It makes up about 3% of the patients that we see in pediatrics and up to about 30% of young adults. Traditionally, this was a very bad diagnosis. If you had Ph-positive ALL and you went to the adult side, you get hyper-CVAD and you'd go to transplant. Cure rate was not very good. In pediatrics, we did a trial several years ago where we used intensified chemotherapy and showed a really good overall cure rate, 87%. But this was our BFM therapy plus some. We threw in some etoposide and we threw in some other things, so it's really, really tough chemotherapy. And in addition to that, we added the tyrosine kinase inhibitor. So the response rate was good, but the therapy was quite tough. Then about 3 years ago, the paper was published where they used blinatumomab in this setting. 63 patients, aged 24 to 82, a 98% CR using therapy with just blinatumomab and a TKI. Second generation TKI, in this case, dasatinib. 24 of the 63 patients went on to stem cell transplant. The others did not, and they still did okay. More recent data within the last year out of MD Anderson took 90 patients aged 18 to age and up, and the median age was 51, with recently diagnosed Ph-positive ALL, 13 with relapse, 72 with newly diagnosed, and they gave them a third-generation TKI, ponatinib, with blinatumomab. 87% of the newly diagnosed patients had a complete molecular response, and 79% of the relapse refractory patients had a complete molecular response. None of those patients went to transplant. I'm going to mention CAR T really quickly because Chad has given me the eye, literally just for a few seconds. CAR T is taking advantage of that same kind of mechanism that happens with the antibody. You got the CD19, you got the CD22. Rather than designing an antibody to attach those, what if we could make a T cell actually do that for us? Then rather than just giving the drug, you could have a sustained effect. You could give them the T cells could hang out for a long time and kill the leukemia. Great idea, right? This was developed at the University of Pennsylvania about 15 years ago. The first patient was actually a CLL patient, an adult patient, but the most famous one was shortly after that, which was a young girl who had multiply relapsed ALL. I think she had already had 2 transplants, and she was dying. And they gave this that, and that young girl is still alive. And that was kind of used as a way, media-wise at least, pushing CAR T therapy. Mechanism behind this is relatively simple. Take the T cells from the patient or from somebody else. You modify them in the lab so that they're expressing and go after either the CD19 or the CD22, give them back to the patient, and they attack the leukemia. We currently have multiple constructs. The only ones that are FDA approved right now are 2 versions of the CD19 CAR, which is interesting. This is one of the few cases where something was approved in pediatrics before it was approved in the adult world. CD19 CAR's Kymriah was actually approved to patients aged 25. I don't know why they stopped at 25. No one knows why they stopped at 25, but they stopped at 25, which really made it frustrating when you were doing AYA oncology, because if you had a 26-year-old, you couldn't give them CAR for a while, right? But we now have a CAR, Tecartus, which is actually approved for patients over the age of 25, right? So we do have something to give them at least. And there are currently multiple trials underway using CD22 CARs. They're looking really good, though I'll tell you that most of those data are showing a little bit more toxicity than we see with CD19, and then also combine CD19 and CD22 CAR trials as well. And then really exciting, NK. NK cells are I'm in love with the data on NK cells. I think they're going to really be revolutionizing our treatments of leukemias. Okay. They compared the 2 different versions of the CD19 CARs recently. This was within the last year, and this is also a really interesting design study. Because we're making advances so quickly in ALL and in CAR therapy, there are these real-world trials now where basically every center who's doing something can participate in them rather than just having trials done at a couple centers, right? This is really increasing the rate at which we're getting data in. So this is real-world data on the use of CD19 CAR. And basically they showed that both of the CD19 CARs seem equivalent for the most part in terms of overall survival. And now quickly, in literally one slide, T-cell ALL. It's easy. Give nelarabine. Really, in the backbone of BFM. It increased overall survival. It was already relatively good with BFM therapy for T-cell ALL at 82%. It's now over 90% if you incorporate nelarabine into, and you give Capezi methotrexate rather than intermediate dose methotrexate. And so, who to transplant? Who knows? I'm not kidding when I say that. I literally just came from a meeting where all the world's experts were talking about this, and no one can give you a good answer to that. For the most part, we'll tell you in pediatrics, you're going to transplant somebody who is MRD positive at the end of relapse if they are not MRD negative at the end of consolidation. Probably patients that are pH-like at the end of consolidation if they're not in remission. Probably. Probably not pH chromosome positive ALL anymore, at least I wouldn't, right? And just so you know, so even with all this information, survival disparities still exist. Multiple studies have now been done where they've looked at pediatric centers versus adult centers and places with AYA programs. And it turns out that it's not just the therapy, it is the supportive care that goes on and the approach to these patients, because the survival rates in pediatric centers using pediatric protocols for young adult patients are higher than using the same therapy in most adult centers. Right? And probably even higher if you go to a place that actually has expertise in AYA. So the rule for that would be, for your AYA patient with newly diagnosed BLL, enroll in a clinical trial if there's one available. Absolutely. Refer to a center with an AYA or to a pediatric if it's a young AYA for the therapy. Provide age-appropriate supportive care. This is so important. Fertility preservation before you're going to be giving chemotherapy, psychosocial support that's at target for them, career counseling. These are people who are in college or just starting their careers or their families. They have a lot of special psychosocial needs that need to be addressed. Treat with pediatric or AYA-specific therapy, as this is translated into significantly better outcomes. Incorporate blinatumomab into this therapy because it seems to probably work. Can't tell yet, that data I showed you is new, but it's probably where this is going. And if you have a pH-like mutation, consider adding a TKI or a JAK inhibitor. And if MRD negative after induction or consolidation, probably don't transplant them. Okay, we're making amazing headway in ALL. I think it's going to get nothing more but more exciting, and I do think that we're probably going to be treating this disease in the chemotherapy-free way, probably within the next 10 years. But that's just my personal take. Thanks. Questions, and then we get out to the second line.